Welcome to the Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. Today we have a very special guest with us, Helen Dao. She is the founder and CEO of Dao Consulting. Helen, welcome to the program.
Thank you. Good morning, Tom. Thank you for having me in the program this morning.
Awesome. I'm glad to be here. You bring some unique insights to the shift, if you will. And there's a segment of the market not a lot of people talk about. And that's there is a lot of talk about the underserved. What do you mean by that? Is that my general practitioner needing to provide service to the underserved? Or is there does the federal government support the underserved differently? I think it's all the above, but you specifically focus in the FQHC, patient-centered medical home arena, and I think you're going to bring a lot of subject matter expertise to the table as we talk about this shift towards virtual care. So, Helen, tell us a little bit about yourself.
Yes, so I'm actually living in Bergen County in New Jersey, and back in 2007, I founded Dao Consulting Services with the purpose of working with community-based organizations and identifying ways of improving quality of services for individuals in the community. But very quickly, I realized the great need of working with federally qualified health centers, FQHC, and the type of population or groups they serve in the health centers. And I became very interested in the diverse type of services that they provide, not only to the underserved population, but just like anyone else. Anyone can actually access services through FQHC. We have been focusing in providing transformation of systems and quality transformation initiatives with the FQHCs. We don't just look at the improving the quality of health care for patients, but also we help organizations to achieve maximum reimbursement through performance improvement and system change. One of the areas that we specialize on is the patient-centered medical home, and where we provide the technical assistance consultancy services to the FQHC and how not only to apply for patient-centered medical home accreditation, but also how to integrate into the fabric of the daily operations of the organization.
Interesting. So there is a strong correlation between an FQHC and a patient-centered medical home entity. Tell us a little bit more about patient-centered medical home and why there is such an integration or alignment between the two entities.
Yes, absolutely. Patient-centered medical home, as we know, is a National Committee for Quality Assurance organization that accredits PCMH or patient-centered medical home. And when we look at the building pillars and the framework of patient-centered medical home and the vision and the goals of the federally qualified health centers, we do see a natural connection between both. But we also need to take a step back and really define what the purpose of a FQHC is in order to see that natural connection. And FQHCs, they really strive to provide complete care of services, not only to the patient, but also to the families. And, we do have a 360-degree view of what those needs are. We look at FQHCs providing not only the physical care for patients, but also the mental, the social, the cultural, and the community resources that the patients and the families need. So the PCMH framework seeks to do the same thing in making sure that patients and the families have access to high quality of care and have access to different resources. To care on the PCMH framework, we look at caring for the patient as a whole person and making healthcare accessible to them high quality, and also to be cost effective to the patient and to the payers as well.
Interesting. Very interesting. So it seems to me the more I talk about FQHCs and patient-centered medical home, that it seems to be a model that helps a regular practice, not necessarily FQHCs from a funding perspective, but PCMH from a quality perspective on how do I get the value? Because we're so stuck sometimes in this wheel about ambulatory care, episodic care, right? But we really need to get to value. And to your point, it's not with an FQHC, it's not just about the patient, right? It's about their ecosystem. It's about their family, and it's about not just the sore throat that they're in to the doctors to talk about. It's about other things that might affect the overall health and safety of that individual. Talk a little bit more about how a patient-centered medical home model might be well positioned to help a regular provider, if you will, adapt towards a value-based care model.
Yeah, no, absolutely. Patient-centered medical home model, you're right, it's not exclusive to FQCs. This is, something that has been going on for decades now. It really started with that solo practitioners. So PCMH model is also integrated and applicable to any a primary care practice. So not just to the FQCs, but the uniqueness when it comes to PCMH and FQHC is that natural linkage they have in regards to that high level of services they are seeking to provide to any individual, regardless to the ability to pay for services. And I think that, with FQHCs, that's something that is very important. One thing that I do want to mention, though, FQHC does not only serve individuals that are, identified as being vulnerable or, of being Medicare beneficiary, but anybody, as I said at the beginning, can actually access those services. How other practices can benefit from PCMH is really looking at the PCMH model as a way of doing business, as a way of integrating all those pillar components of a patient-centered care, where there is being proactive. So we do not want to be reactive to the healthcare needs of the patients, but we also want to be proactive. What are the systems that we have in place to assess what the patients need? How can we be more cost effective in regards to what type of diagnosis tests we are referring our patients to have if they need them? Specialty referrals that we are giving to the patients, and how we are tracking those referrals where we are sending patients to make sure that they are, fulfilling those appointments and being screened. For example, cancer, especially during this time that we have almost more than a year that a lot of patients have not gone for the regular health maintenance of cancer screening. So how can we make that a priority? So PCMH model is for any practices that are willing to make that commitment and are really ready to make a change, a transformation, and taking the entire team through that process. So they have to be buy-in from all levels of the practice. So not just from the management, but also from the front desk staff as well. So, for practices, that's very important to see that what the value is in it.
Very interesting. So as I was asking the question, I was reminded about an article I read just last night, and it seems that you and Dao Consulting are on the leading edge of where this market is going, and this is the reason why. So I'm going to just read this. I'm not sure if you're aware, but just this week, CMS and the Center of Medicare and Medicaid Innovation, CMMI, released a white paper called Driving Health System Transformation, a Strategy for the CMS Innovation Center's Second Decade. And here's a quote from CMI, which is reflective exactly, I think, what you just said to many degrees. The strategy is to shift the current U.S. healthcare system toward becoming a health system that achieves equitable outcomes through high quality, affordable, patient-centered care. And it would seem to me that at its core of that, although they didn't say it, and I know you didn't read it, so you don't need to comment, but it seems to me like patient-centered medical home is a model that they're going to adapt over time. I'm putting words in their mouth, but it would seem to me in order to provide patient-centered care, there would have to be some consistent model for health systems to adopt, whether you're an FQHC or not, in order to achieve those particular objectives. I can't see CMS saying, hey, let's do it differently, right? Let's create a different patient-centered model, right? The model's already there. NCQA has done a great job. Folks like you and your organization have implemented this time and time again, and it works. We do know statistically that the quality of care within the patient-centered medical home construct is higher than a non-patient-centered medical home construct. So that's all good news. So I applaud you for being a forward thinker and adapting to models that maybe not have been prevalent, if you will. I believe the number is something like only 15. I think the number that I read was 15% of all health systems are patient-centered medical home certified. So very interesting. So it's not the norm, but it sounds like we might be moving in that direction. So Any thoughts?
Yes, no, I think that, thank you for sharing that. Absolutely. I think that for FQHCs, one of the things that we do see with the different FQHCs that we work with is there is a development of a true understanding what it means to provide patient-centered care and what it means for the patient. So ultimate goal is to increase that patient satisfaction. But also to increase the providers and the care team satisfaction that they are providing continuous of care for that patient, not only when the patient comes to the office, but also wherever the patient goes. That care team follows them as they are, following those PCMH framework guidelines. So it's definitely one of the things that's a model, as you mentioned, that we know that it works. And why have 10, 15 different models where we know that this model works, and how we can take best lessons, best practices that can be implemented. So it is very exciting to see that the strength that patient-centered medical home is taking place right now. Specifically around the FQHCs and the drive that they have. Every year, you will see that there is a new FQHC achieving patient-centered medical home. As a matter of fact, we are working with a couple of community health centers that are in the process also of applying for the first time to become a patient-centered medical home. But the work to become that, it starts very early on, even just in the vision of becoming a PCMH accredited or organization.
Interesting. If you're just tuning in, you're listening to The Virtual Shift. I'm Tom Foley, your host, and I'm speaking with Helen Dao, founder and CEO of Dao Consulting, and we're talking about FQHCs, patient-centered medical home, and we're about to go into a related topic. You just talked about FQHCs and patient-centered medical homes and following the patient. To me, that starts to talk to a continuous care model. It's not episodic, and it's not value-based, if you will. And I get value-based from a payer's perspective. But from a patient's perspective, I can go to an FQHC and get a continuous care model because you're going to follow me, I think what you alluded to earlier, anywhere, if you will. So that talks about how do I, when I am home, when I'm at work, hypothetically, or anywhere, how does virtual care, and when I say virtual care, I'll define that as telehealth, remote patient monitoring, remote therapeutic monitoring, chronic care management. Those are the different funded programs that providers can take advantage of today to provide this continuous care model and the patient. And so the question is, how does all that integrate with a patient-centered medical home construct?
Mm-hmm. Yes, and that's a very good question. We are living in an era where virtual medical care has taken and strong because of, due to the pandemic, but it's something that we have wanted to do for a very long time in really moving patient care at a virtual level. So here we are today with, practices, FQHCs specifically, really working towards that goal. And how do we transition patient-centered care to a virtual model? And we first need to take a look at what patient-centered medical home is, the care that happens in the office. What is the care team that is in place? What are the systems that are in place in order for this to work? Not only, as I mentioned, during the visit or even prior to the visit, but also what happens when the patient leaves the office and continue providing that continuum of care. In order to bring this to a virtual level, we need to move a lot of those elements in a virtual model. For example, it's not just the patient having the telehealth encounter with the provider, but we also need to make sure that the other services and the rest of the care team follows that. For example, behavioral health services, that the patient has virtual access to behavioral health services, that the patient continues to have access to care coordination services that typically you would do either in person at the office, but now you can not only continue doing it over the phone, but you can also have that face-to-face encounter via a video as as we are having with the providers, and making sure that there is also remote monitoring for patients with chronic conditions, for example, patients with hypertension or diabetic patients, so that we are understanding what's happening with that patient, and that we continue to provide 24/7 access to medical care and medical advice, that the patient knows that that care team, it's available to them 24/7. So really shifting the mentality that it is only the responsibility of the provider to provide patient-centered medical care, but it's really the responsibility of an entire team. And in the virtual care, doing telemedicine, we need to be able to start moving all those important components of PCMH to a way that patients have access to those services in order to make sure that they are getting the best quality of care they have.
Yes. So, in the context of COVID and the clinic is not always available, and the idea of, the old model of come and sit in my waiting room, it seems to be gone because, you got a collection of a lot of different stuff in there, right? So you got people with cough and cold, you got the flu, you got pink eye, you got, go down the road of all the different contagious things. I'm blowing it out of proportion, obviously. And, all the different contagious things that might be sitting in your waiting room. But at the same time, I do see, so that model of, how do I get access to care in a team-oriented approach might be that virtual care. But virtual care is more than a video discussion, right? So for that true home, that physical home to be the center of care or a setting of care, it would seem to me that as part of maybe remote patient monitoring, providing them a medical device, such a blood pressure cuff or glucose to do obviously to do a better job of managing A1C. So the point there is that there seems to be, well, I know remote patient monitoring provides the investment necessary, but I'm not quite sure everyone understands that the investment is there to take care of those 6 out of 10 patients that have a chronic condition that are more the frequent flyers, if you will, into a clinic, and take care of them where they might be from a remote patient monitoring perspective. Do you see challenges rolling out virtual care in a patient-centered medical home (FQHC) type of model? And if you do, what would be some suggestions that you might provide?
Yes, there definitely are challenges, with moving PCMH model to a virtual care in regards to what the systems are that need to be implemented. And I do have to say, Tom, that we still have a waiting area, even as we provide virtual care.
I know you do. That's true.
So,
I'm with you.
we still do. And so,
but I know in my provider's office, sometimes they have you waiting in the parking lot. And then they call you, and they know you're there, but they call you in. So there are some precautions which is the right thing to do. Right. But the models are shifting in the context of they're not filled with 20, 30 people anymore.
Right, absolutely. So I think that one of the things that we need to look at is communication. Communication, not just among the care team members in regards to the practice, but also with the patients. And there are some challenges that we do see when it comes to telehealth medical care that FQHCs are providing. And some of those, are around the technical challenges or training challenges for our patients. Not all patients might be interested in doing telemedicine care for different reasons. One might be the technology that they have might not allow them to do that. Also, when it comes to health literacy can also, or even virtual literacy in a way, can be a challenge for some of our patients. And how do we close that gap if we are really trying to successfully move to a virtual PCMH model? How we are going to be able to do that to sort of overcome some of those challenges. One of those way of doing that is, as I mentioned, having that communication, but also continue deploying some of other interventions such as community health workers. How are the community health workers a key component in the implementation of PCMH model in a virtual setting? Is having that contact with the patients and be able to providing that support that they need. Also, it can have a potential decrease in the continuity of care if the transition is not done properly. And what I mean by that is that we want to know when the patients, if a patient goes to the hospital, what is the type of follow-up that we are giving to that patient within the time frame that is needed. If they are discharged from the hospital, we need to be able to stay engaged with that patient and provide the appropriate follow-up and make sure that they are being connected to the primary care provider in order for them to have that follow-up conversation of what happened during the hospitalization or what happened during the ER visit. That's very important. And, and we need to also look at what are policies and procedures that we have in place that we provide that guidance and how to effectively do patient-centered medical home in a virtual setting. So all those things, can be a challenge. But at the end of the day, what we see is that when some of those challenges are happening is that the communication, how is the team communicating, not just, as I mentioned, within the practice, but also to the patient and how they can strategize in becoming some of those challenges.
Yeah, so communication is the key to success, I always say. So I hear you there. And you hit on a good point, and we're probably going to have to bring you back to talk more about that. And that's about the technology literacy and these applications. I've deployed telehealth into the Bronx, New York, and which is one of the poorest congressional districts in the U.S., unfortunately. So I've seen firsthand the challenges of adaptation of technology into the hands of the person in need. That, as well as, not everybody speaks English, and just changing the language relative to communication being the key to success. There are successful ways of how to engage patients regardless of language, and getting them the care that they need and having them understand what their responsibility is towards a better state of wellness. So, last words?
Well, yes, I really believe that patient-centered medical home model, it's really the way for FQCs in particular to provide that high level of care that the patients need or the community members need. And, one thing that I do want to say that as we are continue to go through the challenges that we experience because of the pandemic and because of other things that are coming up, a shortage of staff, we can't ignore that. We need to stay positive because even if you make a small change and a small change at a time, it can definitely have a tremendous impact in the quality of life and the quality of care that the patients have. So we are not to be discouraged. I feel very optimistic that this is just going to make us more resilient and much stronger. And we are going to even come up with more innovative ways in how to care for our patients and our families. So, it's just I wanted to give some words of encouragement to, our colleagues and to the practices that are really trying to figure out how to make this work. But I think that, let's take small changes at a time, and those small changes will definitely have a bigger impact in the lives of the people that we care for.
Awesome. So Helen Dao, founder, CEO of Dao Consulting. I believe that's DaoConsulting.com, if I recall correctly.
Yeah, it's DaoConsultingServices.com.
Spell Dao for us, just so people know.
Oh, yes, it's D as in David, A-O.
DaoConsultingServices.com. Awesome. Helen, I appreciate your time. Your subject matter expertise and guidance in this discussion was awesome. And I look forward to having you on the program again.
Thank you. Thank you so much, Tom.
I would like to thank the show sponsors, both HP and Intel. HP Engage long lifecycle products provide the stability, safety, and security you need, plus flexibility and performance designed for today and tomorrow. As well, Intel would like you to know we're going above and beyond together with new standards for business with the latest Intel vPro processors, delivering what IT needs for performance, security, remote manageability, and stability. And be sure to check out the program page on healthcarenowradio.com. And remember, connect or follow me on LinkedIn, Twitter, @FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.